So good day. I'm Sandro Galea. I'm Dean of the Boston University School of Public Health, and welcome to our latest Public Health Conversation Starter. This is a series of discussions we are having with thinkers who can provide a critical perspective on the work of health and public health. Today, I have the privilege of welcoming Dr. Martin Shapiro. Dr. Shapiro is a physician, health services researcher, and professor of medicine at Weill Cornell Medical College, also a distinguished professor emeritus of medicine and public health at University of California, Los Angeles, where he served as chief of division of general internal medicine and health services research for 25 years. He previously wrote the book, Getting Doctored, Critical Reflections on Becoming a Physician, and his latest book, which we're going to talk about, is The Present Illness, American Healthcare and Its Afflictions, that is just being published by Johns Hopkins University Press. I'm really delighted to welcome Dr. Shapiro. Dr. Shapiro, welcome. Thank you for joining us.
I'm delighted to be here.
So let me start with the book and to really start at the beginning of the book in the prologue. You characterize the U.S. healthcare system as a patient who may not survive. And what, in your view, are the main, let's use the word afflictions of the American healthcare system that have put it in such jeopardy?
Well, there are some that are widely recognized that it's far more expensive than that in any other country, that we don't have particularly good outcomes, and access to care is very far from optimal and much worse than in almost any other advanced country. But as I thought about these problems in the course of working on this book over the last number of years, there are some underlying issues that are, I think, rather broader and that affect the ability to change the system. One is commodification of healthcare and of health. That is teaching it or treating it as a good to be exchanged in the marketplace. And this goes on not just in the pharmaceutical industry and corporations like that, but also in the what have now become very corporate hospital systems and clinical systems. It's among doctors and their professional groups in the practice of medicine. It's also true of scientists. Since the passage of the Bayh-Dole Act, there's the opportunity to obtain royalties and equity in companies related to their discoveries. And it's also true among patients and the public. Healthcare, obviously, having become so expensive, everyone wants their piece of the pie, and many people push for more care and not necessarily thinking about, well, is that appropriate in the context of taking care of everyone in society? So commodification is one thing. A second thing is what I characterize as consciousness, which is the attitudes, the values, the expectations, the needs, and the competencies of all these different groups of actors in the health system. And a lot of people have needs or expectations that drive the cost and drive the disparities in certain ways. Doctors, I think, are not well selected into medical schools as people who would be caring and devoted to serving the larger society. And many of them are driven by prestige and potential for income. So they preferentially tend to go into the specialties that pay the most by doing procedures. The corporations do not have a sense of obligation to society. We see the obviously awful behavior of the pharmaceutical industry, even raising the prices of drugs that have been around for a long time, but also the hospital corporations and even the nonprofit ones like the teaching hospitals, which are interested in promoting their product lines and generating a large surplus. And so the values are and attitudes towards it all are not what would be consistent with making an effective, efficient, and just system. And then many people have intense needs, not being well served by society. In the US, we spend less on social services and other financial services for those in need. And many people come to medicine seeking a heart, as I characterize it, in an otherwise heartless world. But medicine is not, doctors are not well trained to provide that care. So many of the people in medical school aren't effective communicators, aren't particularly interested in relating to patients. And these are intense problems.
All right, so I want to tease apart two of those, but I want to talk about the commodification, and I'm intrigued by the selection of physicians. But let's start with the commodification, which I think it's an argument you make compellingly, and I think it's I suspect anybody looking at watching this will agree with that. But what's the solution? It is how do you take something that is so embedded in multiple aspects, multiple systems, and actually transition away from it?
Well, I don't think it's easy, and it's not that healthcare is commodified in a society in which everything else isn't. You know, healthcare is very much part of society, and so I don't think there is a simple solution. I think there are certain things that could be done that could help. I think not paying doctors for procedures, but rather paying them for their time would be an improvement. So there wouldn't be an incentive to do things that people don't need. I think that in terms of hospitals, changing the reward system so they're not rewarded for doing expensive things and for keeping away people who are perhaps underinsured. A lot of them don't want to take care, certainly of the uninsured, but even of Medicaid patients any more than they have to, because they can glean a lot more revenue from other sources. In terms of the scientists, I think the rewards from research that's almost all funded by the federal government should accrue to the federal government, perhaps to support more research. So I think all of these are things that could help to some extent.
I often think that changing payment structures would be a really a seismic shift in this country. And of course, there are many such efforts going on, and different systems have different payment structures. But in the main, we remain a system that is driven by a fee for particular service, fee for particular. I suppose my question is, do you think it's realistic? And what do you think would be the where would the key lever be to shift to a way where payment incentivizes keeping people healthy?
Well, there has to be policy. Government is ineffective. They don't regulate the FDA well. They don't regulate Medicare fees well. So they're not taking that kind of initiative. Obviously, there's great pushback from many medical specialties about changing the arrangements. There's an update committee for the Medicare fee schedule that meets, and it's mostly representatives of medical specialties. But 2/3 of the membership are procedural fields, and they won't give an inch towards having more of the more or less fixed amount of revenue go to the fields that are not ones that primarily do procedures, which some people call cognitive fields. So it's not simple. And I think I argue in the book that it's very hard to pull a policy lever and solve a problem, that you have to address the consciousness, the attitudes, and the values in society. So I think changing the attitudes of the medical profession, probably at the very least, starting with the people who are entering it, may eventually have some impact on the level of resistance to those kinds of changes.
Yeah, no, and I appreciate, and you're very careful about this in the book, to say this is not a simple solution that's going to happen anytime soon. And I appreciate your focus then on the future. So let's talk about that for a second. How would one even go about changing how we select medical students? I mean, there's mechanics. I get the mechanics. I understand the different checklist, but it strikes me as it's a larger philosophical and requires a cultural shift to attract and to admit different kind of people into medical school.
Well, there has been this attitude back to the Flexner report written in 1910 that it's in the preface to the report that we're better served by having fewer medical schools and a more elite medical profession. And a lot of these schools that were serving or producing practitioners that were serving a broader population eventually closed down. I think that practically speaking, why do we need science requirements before going to medical school? Why not train people within medical school in what science they will need? I mean, people who are going to be scientists need an advanced level of scientific training. What's seriously lacking, if you look at the majors of the people entering medical school, is people with backgrounds in the social sciences and humanities, and certainly people who have demonstrated a commitment, a meaningful commitment to society, not just went to Uganda and dug some wells so it looks good on their application form, but evidence of a meaningful commitment. You could argue perhaps business schools don't take people right out of college for the most part. They expect them to go out and have some real world experience. Maybe medical schools could do that more. Maybe we could have communities that are underserved medically select people for medical school. So there are lots of things that we could do. Get rid of the standardized tests and grades as the primary criteria, but some assessment of people's values, their ability to connect with others and empathize. And yes, of course, we want some people who are going to be scientists, but we also want people who are going to be caring physicians and responsible physicians and physicians who care about the greater good, the common good, in addition to the welfare of the patient who's right in front of them.
Are there other countries that do this better? I'm not talking about all of medicine. I'm talking actually specifically about the selection of medical students. I'm actually curious. Are there lessons to be drawn from other places?
I haven't studied that. I think in a lot of European countries, the approach is that people enter medical school as a first and not a second degree. And so there may well be less socioeconomic selectivity along the way there. So that would be a consideration. But in terms of a very broad effort to take the focus away from the biological reductionism, which dominates the medical profession so much of the time, and the orientation towards doing more and more procedures and less caring, I don't know of a country where they've solved this problem. Maybe the US could become a leader.
No, that would be that actually would be really an interesting challenge to us to do so. And I agree with you that the US could lead on this. Let me shift tack for a second and talk about COVID, because we are in the peri or in the twilight of at least COVID being front and center in our minds after 3 years of COVID. Mm-hmm. Can you comment a little bit from your perspective on how the shortcomings of the healthcare system intersected with our collective shortcomings in dealing with COVID?
Uwe Reinhardt, famous Princeton economist, once said that America doesn't care about the welfare of a child unless she falls down a well in Texas, a famous episode. And I think that the hundreds of thousands of excess deaths and over a million total deaths from COVID don't seem to reach people. I mean, and we do know that there are groups that were at greatest risk for dying of the disease, for getting the disease, and often many of the factors that correlated with it were things that correlate with being disadvantaged. There's also a lack of a real coherence to the public health effort in the United States. Of course, this is your domain, but some of the things I've done that involved interacting with CDC and public health departments. CDC is very dependent on public health departments to cooperate. And so essentially we have 50 or 51 programs plus the CDC trying to keep all the balls in the air. That there isn't a coherent approach. None of us like what China did, and in some ways it was catastrophic. But at least some other countries, there seemed to be more coherence or perhaps more acceptance of central direction as to what the programs should be. In Canada, where I'm from, and I know you lived for a while, Um, uh, there wasn't the level of, there was certainly resistance in certain quarters to COVID vaccinations and restrictions and so on, but it wasn't anywhere near at the level in this country. And well under half, I think closer to 40%, the death rate from COVID that there was in the United States. So I guess the question is, how do we create a set of values and expectations that everyone's life matters? Because in this country, everyone's life doesn't matter. You know, deaths that occur among the poor, people ignore, they shrug. They say, well, nothing we can do, and we've got to protect our freedom. So there's lots to change.
The more one thinks about these things, the more one comes to the feeling that it's ultimately about values.
Mm-hmm.
Let me ask you go back to the healthcare system. I'll ask you two more questions. Whenever we get into a conversation about reforming healthcare in this country, it becomes politicized very quickly. And I don't think it's politicized as much as partisanized. It sort of becomes a matter of belief in red or blue terms. So I suppose my question to you is, do you see particularly fruitful avenues for bipartisan agreement on elements of the healthcare system that we could actually improve in the, I won't even say short term, let's say in the medium term?
Of course. I mean, I think the Republicans are a little embarrassed about the price of insulin, but they often feel like they have to defend corporate interests, or enough of them do, that make it hard for the party to move in that direction. I think the broader question, I mean, I think a fundamental question about equity is that people don't have the same insurance, and separate is never equal in healthcare or in any other part of society. And having the same health insurance for everyone seems an essential element of moving towards having equity in the system. And it's hard to see how you get there with so many corporate interests opposed and so many people feeling like it's a particular agenda. You know, but to call it communist or even socialist to provide people with insurance and coverage is wrong-headed. It's not the truth. But you know, the experience in Canada, which has problems which are largely due to underfunding of the system, which are potentially addressable. But when Saskatchewan introduced the first universal program, 95% of the doctors in the province went on strike, and it was there was a lot of tension. When I was in medical school in Quebec, where the program was introduced, the specialists attempted to go on strike too. They thought it was going to be the end of the world and of the ability to take care of people. But a few months after the program was in place, everyone recognized its value, and the resistance melted away. So somehow there has to be a political solution that overcomes enough of the values, fears, expectations. And I think ultimately people might prove more reasonable in that circumstance.
Well, that leads me to the last question then. So how can anybody listening to this, or anybody who reads your excellent book, best be an effective advocate for moving to a better healthcare system? What do you think are the ways in which good people of good conscience who understand this problem can best nudge us towards in the right direction?
Well, I think that all the actors in the healthcare system and all the public citizens who care about the healthcare system need to, first of all, acknowledge what the nature of the problems are in terms of consciousness, in terms of commodification, and indeed also in terms of the way in which people communicate about health and healthcare. So that needs to be acknowledged. And the consequences of that have to be confronted. And there are many problems that have to be solved. And they won't all be solved at once. But I think there has to be a consensus. I think a consensus that the common good matters, and that, as Robert Vela and others have written, has been lost in America in recent times. As there needs to be an effort to address that incrementally, perhaps at first, and ultimately perhaps we would achieve some greater and more effective change. But I think we all have responsibility here. We're all complicit in the current system, and we all need to take responsibility for trying to change it.
I suppose it comes down to, as many things do, to the conversation, to having the conversation. And it's a colleague once said to me that if we disagree, it means we haven't talked enough. And one of the things that we're trying to do with this series is to have these conversations, to put them out in the water, so that a conversation leads to a conversation, leads to change. Dr. Shapiro, thank you for writing the present illness. I really enjoyed reading it, and thank you for joining this conversation. Thank you for everything you do.
Well, thank you very much. And I hope that others will consider the arguments I've put forward and offer their corrections and improvements so that we can get going and try to do something about this highly dysfunctional healthcare system.
Dr. Shapiro, thank you. Thank you for everything.
Thank you.
Take care.